Assalamu alaikum. I am Dr. Muhammad Ali Rabani. I am demonstrator and part 2 resident of FCPS Anatomy in CMH Institute of Medical Sciences Multan. Today we are going to discuss the gross anatomy of peritoneum. By the end of this lecture, you should be able to define the peritoneum, tell about its layer and its extent, enumerate the intra and extraperitoneal organs, define the terms mesentery, omentum, ligaments, folds, recesses, pouches, gutters, trace vertical and horizontal disposition of peritoneum, describe the role of peritoneum in normal and pathological conditions, and elaborate the blood and nerve supply of peritoneum and its clinical importance. What is peritoneum? Peritoneum itself is a thin serous membrane that lines the wall of the abdomen and pelvic cavities, and it includes the viscera also. This word serous membrane, it means that it is a simple serous membrane. It is a simple squamous epithelial lining that has a basement membrane, and the top of it there is a flat epithelial cells on it. So it is just like the flat simple squamous epithelial cells that you have studied in general histology. So serous membrane is nothing but a continuous simple squamous epithelial lining that covers the cavity walls and the viscera themselves. A very good example of understanding the peritoneum is that of a balloon, punching a balloon. Let's suppose you have a balloon right here, and it's a simple balloon filled with air, and you can analog it with the walls of the abdominal cavity. The viscera that enter, you can be give example by the punch. They enter from the balloon by the side. Mind it, they are not entering through the opening, or they are not forming a new opening. They are entering from the wall. When they enter through the wall, you can see a portion of the wall. It becomes adherent to the hand. This portion of the wall that becomes adherent to the wall, this is now known as visceral layer, and this layer that remains in its original position lining the cavities, that becomes the parietal layer. As the punch goes on, the pressure will rise, you will have to let the air out. As the punch will go inside, the air is let out. You see that this space between the two layers, it becomes narrower, and the organs get inside. So in the organs, if we say that this punch was an organ, you can see that it is now covered with almost entirely with visceral layer of serous membrane. The original this parietal layer of serous membrane was there, and the actual cavity of the space that was inside that contained air, that has actually been deflated to a minimal extent. If you see that if whole of the air is released, this layer will be very small like this. This layer will be very minute and will be almost negligible, or it will be none. So now a key concept to understand is this hand is not actually within the space of the balloon. It seems to be in the space of the balloon as it has invaginated with the wall, and while it has invaginated from the wall, it carries with it the visceral layer and the membrane, the layer that was actually in its original position, that is the parietal layer. And there is a point, in this case it's the rest point, where the visceral and serous layer they meet one another, that is known as reflection. So that is the basic theory behind every serous cavity. This is the theory between the pericardial cavity, peritoneal cavity, pleural cavity. In case of peritoneum, you can see it very well in this demonstration in the lower bust. Here this is the gut, you can consider it stomach, small intestine, any part of the gut, and here the visceral layer is completely surrounding it. This is the point of reflection. In this case it is extended into a long form, so it is known as mesentery, and after mesentery there is the lining that actually lines the body wall. It lines the posterior body wall laterally, anteriorly, that is known as the parietal layer. So this is the parietal layer, and this is the visceral layer, and this is the mesentery between them. So this is the concept of peritoneum, and what are the structures that are lining the viscera, and what is the membrane that is lining the body wall. So this has been generally shown in the pictures, like you can see this is the case. So in the yellow color you can see that there is gut tube. Gut tube is being surrounded by this layer of membrane that is known as visceral layer of peritoneum. Here all of the body wall, it's covered by parietal layer of peritoneum. here between them there is a connection that is known as mesentery, in this case dorsal mesentery because it is towards the back, and all of this empty space between the visceral and parietal layer, it is known as peritoneal cavity. This peritoneal cavity is symbolically shown to be such a large empty space, but actually the whole viscera they expand out and they are touching the walls and sides of whole of the cavity, so there is not actually much space. Practically in this point it is very much collapsed space containing only a few millimeters of fluid. There is an exception in the foregut excuse me, in the foregut, in the part of lower part of the in the foregut, in the abdomen, lower part of the esophagus, anterior lesser curvature of the stomach, and the first part of the duodenum, first half. They also have an additional mesentery on its anterior aspect that is known as ventral mesentery. We will discuss more it in detail in embryology. So by now we discussed what is parietal layer, what is visceral layer, what is peritoneal cavity, it is between these two layers. And you have seen that in example of the punch, the peritoneal cavity, actual cavity was not entered by the punch. The peritoneal cavity actually, the actual peritoneal cavity, it's a closed cavity in males, and the organs are present basically outside, surrounded by visceral peritoneum. They are not present actually inside the cavity. However, in females, this cavity has a potential connection to the externum, and that is through female genital tract, through the vagina, cervix, uterus, and fallopian tube. The abdominal end of the uterine tube is open. It is open into the peritoneal cavity. So this female genital tract may give a potential space for the passing of any sort of scope for the passing of, actually it is for the passing of the ovum, and it is for the passing of the inflammation. If it as there is ascending pelvic inflammation, it may go inside. So here is we are all about it. I have added this picture to show that this actual peritoneal space, it's a symbolic gesture. Otherwise this whole of the space is filled with a lot of organs. There are coils, there are visceras, they are opposed to one another very closely. So the space is there just like the basic principle, but that space is very much limited due to the organs. So before going into that, hey, you take this example. You should know what is the intraperitoneal and extraperitoneal. I like to emphasize very much the word intraperitoneal and how it may be misinterpreted. So you just say that it's an organ, here an organ is there, and there is a cavity in front of it, peritoneal cavity. It's lying outside the peritoneal, it's extraperitoneal, simple as that. Let's say the organ moves forward. The organ is now here. It now indents the peritoneal cavity like this. Now here you can see that it is being lined on three sides, like here, 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 but it is not lined on the posterior aspect. It is not completely enveloped. Now it is again considered to be an extraperitoneal organ because it is not completely enveloped by peritoneum, and this will again be considered as, because it's extraperitoneal, so this will be considered as parietal peritoneum. If it moves even further, and it reaches here, so when it reaches here, the membrane is covered like this. Now it is known as intraperitoneal organ. This particular image is shown here. Now it is known as intraperitoneal organ, and you must again, I am emphasizing that intraperitoneal means that it means that it is not within the actual cavity. Yes, it is being lined by the peritoneum surround completely, and it seems that it is within the cavity, and this visceral layer that is surrounding the organ, it is continuous with the peritoneum of the back or peritoneum of the walls with the help of this connection that is known as mesentery. Mesentery is always double layered, and it gives a pathway for the blood vessels, lymphatics, and nerves to reach the gut. Now this is the concept of intraperitoneal organ. Now this is the concept of extraperitoneal organ. So here it is shown in this particular picture, the extraperitoneal organ has been shown. Sometimes what happens is that embryologically some rotation, some movement also occur, that they move the organ, the gut, from their original position. Let's say the gut is moved in the direction of the arrow. When the gut is moving in the direction of arrow, what will happen is, you will see the peritoneum will be something like this. The peritoneum is something like this. It is still intraperitoneal, but its whole mesentery, it's now attached to the posterior wall. With time, this attachment they fuses with one another and they get absorbed. And when they get absorbed, we return to the same position. So what is that? So we return to the same position, that will be like the organ is here, the peritoneum is like here, and here will be a remnant of what was actually the mesentery. So it again becomes a retroperitoneal organ. So what's the difference between the retroperitoneal or extraperitoneal shown here and here? So this was never an intraperitoneal organ, it was originally placed here. So this is known as primarily retro extraperitoneal organ. But this particular organ, it was actually once an intraperitoneal organ, but it later became extraperitoneal, so it is known as secondarily retroperitoneal organ. So this is the difference between intraperitoneal and extraperitoneal, and after intra and extraperitoneal we discuss the difference between the primarily retroperitoneal and secondarily retroperitoneal. Now there are words difference between extraperitoneal, retroperitoneal and subperitoneal. This word extraperitoneal, this is an umbrella term, and this denotes to all of the structures that are lying outside the peritoneum according to the criteria we just discussed. Now the terms retro and subperitoneal, these are relative terms depending upon the relation of the organ. For example, for all of the organs that are in the posterior wall of the abdomen, like kidneys, pancreas, that are behind the layer of peritoneum, they are behind it, they are retroperitoneal. Similarly, for the organs of the pelvis, like bladder, like uterus, cervix, they are beneath the lower margin of the parietal peritoneum. So they are beneath it, so they are known as subperitoneal. So subperitoneal or retroperitoneal are basically just fancy words for extraperitoneal, and they just give an idea about the relation of the organ to the peritoneum. So kidney will be considered as retroperitoneal, bladder will be considered as subperitoneal, both are extraperitoneal. So this is a little complex structure, you don't have to understand actually. So here basically I am wanted to show you this. This is the in the red color, that is the peritoneal lining. Here there are complex folds and all that, a little tracing needs to be done. So this is the peritoneal covering. So what I wanted to say that here, that is the last limit of the peritoneum. Here anything behind this is retroperitoneal. So here you can see that these kidneys are retroperitoneal organ, this inferior vena cava is retroperitoneal, this pancreas is a retroperitoneal organ, and so on. So this is the difference between the retroperitoneal and subperitoneal. Then pancreas, this peritoneum, it varies in thickness and density depending upon the organ it's covering. For example, when it's covering the stomach, it has to expand and relax very frequently. You eat, your stomach gets filled, and when with time it gets relaxed. So here the peritoneum is thin, relaxed, elastic. At points where it is covering the wall, where organs are fixed, like in front of the kidney, in front in front of the psoas muscles. So these points, this peritoneum is relatively thick and density is high. So we are done with it. It is always good to know the organ that are intraperitoneal and extraperitoneal. So the organs that are intraperitoneal are stomach, most of the small intestine, that is jejunum and ileum, with the exception of duodenum, cecum and appendix. A very interesting thing about cecum is that it is an intraperitoneal organ, but it does not have a mesentery. We will see that inshallah when we will see the mesentery. And there is extraperitoneal organs. We further divided into three subdivisions: partially covered. Partially covered were the ones that were basically covered on three sides, but not completely within the organ. So they are basically the ascending, descending, colon, and the rectum. Then there are retroperitoneal organ. They are in the posterior wall, duodenum, pancreas, kidneys, ureter and adrenal gland. Then there are subperitoneal organs. They are below the lower margin of the peritoneum, that are urinary bladder, prostate, seminal vesicle, uterus, cervix, and vagina. Okay, moving on to the concept of peritoneal, lesser peritoneal sac, you just have to revise a little much about the concept of rotation of the stomach. Originally, stomach had mesenteries on the both sides. There was a dorsal mesentery In the dorsal mesentery, was developing a spleen, and there was a ventral mesentery, and in ventral mesentery there was developing liver. The word ventral mesentery is not very much commonly used. Why? Because this liver divides the ventral mesentery into two parts. The part that is between the liver and the stomach, that part is known as lesser omentum, that part, and that part between the liver and the anterior abdominal wall, this particular part, this part is known as falciform ligament. So for now on, from on this lecture, I will be using these two terms rather than ventral mesentery. So here is the dorsal mesentery between the stomach and the posterior wall. Within it, spleen will be formed. In the future, we will discuss this connection between stomach and spleen, and this connection between spleen and posterior wall. They changed their name to gastrosplenic and splenorenal ligament. We will discuss them shortly. Then there is a rotation of the small intestine. The anterior aspect of the stomach goes towards right, the posterior aspect goes towards left, the left surface becomes anterior, and so on. This is majorly driven by the growth of the liver. Now you see the cavity is being now isolated here. We will see it further, like here. As liver grows, as it continues to grow, liver go and cover all of this lateral aspect and even the posterior aspect. And when liver grows all the way, liver fuses with the posterior layer and the lateral layer. So if when liver has fused with the posterior and lateral layers, this cavity is isolated. This cavity is now known as lesser peritoneal sac, and its other name is omental bursa. You see, in front it has stomach, between stomach and liver it has lesser omentum. On the posterior aspect, between stomach and spleen, it has gastrico-lineal ligament or gastricosplenic ligament, and from the spleen to posterior wall, that is linorhinal ligament. Here you see that actually the mesentery was attaching in the midline, but due to this rotation, this wall fused with the posterior. When this wall fused with the posterior, you can see here now the pancreas became secondarily retroperitoneal, and the origin of the mesentery that seemed to be towards the midline, now it has shifted towards the left. Now it has shifted towards the left in front of the kidney. When it shifted towards the left in front of the kidney, now this ligament seems to be between spleen and kidney. Now it changes its name to linorenal ligament or splenorenal ligament. So this is about the formation of lesser peritoneal sac in transverse image. Another thing that happens is the stomach not only rotates clockwise in horizontal plane, it rotates clockwise when you are seeing it from the front. Its upper end goes to the left end down, its lower end goes to the right end up. What does it mean? What consequences does it have? Before, you can just imagine the lines of the tension of the dorsal mesentery was like this. Dorsal mesentery was simply directed from the stomach back to the posterior wall. The dorsal mesentery was directed like this to the posterior wall. When it rotates, upper end goes down, lower end goes up. The direction of these fibers also change. The fibers of these fibers becomes like this. The fiber direction, they become like this. So these fibers become like this. So this lesser sac, it not only expands sideways due to this change of fibers, this is due to the rotation of stomach, it now has the ability to extend downwards. Now I will show you in the other pictures. This downward sac, that is known as omental bursa or lesser sac, the name of the one and the same thing. This now it extends downwards. As it extends downwards, you can see that initially it was near the greater curvature of the stomach. With time, it grows over the transverse colon, and with time it grows all the way down to cover the front of the small intestine. So here, if you let me use a ruler. If you cut a line here, like here, if you cut a line here, like this, you will get to know this picture. Here you can see this is the downward extension of the greater omentum. This is the downward extension of greater omentum. This is the downward extension of greater omentum. When it goes down, it takes the cavity of the lesser sac with it. it takes the cavity of the lesser sac with it, and this lesser sac is extended all the way down to this lower margin where the fold is in. And another interesting thing to notice, this is now the extension of a double layered membrane. So it becomes, the omental bursa actually becomes 4 layered. The anterior wall that was double layered, the posterior wall that was double layered. So this is the extension of the lesser omentum, that lesser sac that goes all the way down into the greater omentum, and that's why it has the name omental bursa, because it's the bursa within the greater omentum. Now moving on, with time what happens is that in most of the adults this space does not remain. These layers they fuse with one another. At the same time, this space, this dorsal mesogastrium that was going from on the superior aspect of the transverse mesocolon, they fuse with one another also. So we are left with this, the omental bursa or the lesser sac with a lower floor that is actually now transverse colon, transverse mesocolon, and interiorly it is limited by the membrane of part of the peritoneum that is between the greater curvature of stomach and the transverse colon, gastrocolic ligament, that is gastrocolic ligament. So this is the lesser sac. Now you are ready to listen to the boundaries of the lesser sac. So if you see from anteriorly lesser sac, let me go into this picture. Here in the blue color, the cavity of the lesser sac is being shown. The lesser cavity anteriorly, it is bounded by this lesser omentum. Then it is being formed by the posterior surface of the stomach. Then it is covered anteriorly, it is lined by the greater omentum, the part between the greater curvature of stomach and the transverse colon, that is also known as gastrocolic ligament. So this is the anterior boundary of the transverse colon. Here you can see all of these things here. Here is the lesser omentum, here is the stomach, and here is the space between the transverse colon and stomach. Behind it is actually the peritoneal space that is known as lesser peritoneal sac. Here in the next picture what has been done is that along the greater curvature of the stomach, a cut has been made between the greater curvature of the stomach and the transverse colon into the gastrocolic ligament, and after that the stomach has been pulled up like this. So here it is. So this is the stomach, it is the posterior wall, this is the greater curvature, and the gastrocolic ligament or the part of the this gastroomental ligament or gastrocolic ligament along that is actually a part of greater omentum has been cut. Here now you can see the posterior wall. What are the structures that are making the posterior wall? Here the posterior wall is being made by this structure, transverse colon. Simply speaking, from here to here you can see that this is the mesentery of the transverse colon, this is the mesentery of the transverse colon, transverse mesocolon. Then there is an organ that is a pancreas, that is pancreatic gland. On the top of pancreas you can see the artery, that is splenic artery, here it is going. Here you can see the aorta and aortic branches, mostly the branches of celiac trunk. Here is the celiac trunk and it is giving the left gastric, this splenic artery, this common hepatic artery proper, gastroduodenal artery, and so on. Then here you can see the vena cava, and here you can see the suprarenal gland, left one, and below suprarenal gland obviously there will be kidney. A part of the upper pole of the kidney is visible here, so this pole is visible here, and then you can see the hilum of the spleen here. So these are basically the structures that are forming the posterior wall of the lesser sac. So these are the boundaries. We discussed the anterior wall, the posterior wall, the structures that are behind the posterior wall, and even we can discuss the lateral aspects. This is the peritoneal sac, the posterior wall of the peritoneal sac, this one. Below it is being limited by the attachment of the transverse mesocolon. On the left side it is being limited by the attachment of the splenicorenal ligament or splenicorenal ligament or lienorenal ligament. On the right side, it is being on the upper aspect, it is being limited by the bare area of the liver and inferior vena cava, but there is only one opening, and this opening that allows the communication between the lesser sac and greater sac. This opening that allows the communication between the two spaces, this opening is known as epiploic foramen. So this is the opening. You are seeing the stomach and lesser omentum without removing them. So this is the lesser omentum, this is the stomach, this is the greater omentum below, and this is the lower free margin of the lesser omentum, and here is the epiploic foramen. So what are the boundaries of the epiploic foramen? So this is the epiploic foramen between them. So epiploic foramen is bounded anteriorly by this structure, the part of the lesser omentum that runs between the duodenum and the liver. This part of the lesser omentum, this whole is the lesser omentum. It is said by many names. You can just say lesser omentum. You can say the inferior or right free margin of the lesser omentum. You can say the part of the lesser omentum that runs between the liver and the first part of the duodenum. So this part of the lesser omentum that runs between the liver and the first part of the duodenum, it is known as hepatoduodenal ligament. So hepatoduodenal ligament is nothing but the part of the lesser omentum that runs between the liver and the duodenum. Also, this part, hepatoduodenal ligament, it carries a number of structures in it. It contains portal vein, hepatic artery, and bile duct. So sometimes these structures are also considered to be an anterior wall of epiploic foramen, collectively known as portal triad. So we are done with anterior wall. Superior wall is made up of caudate lobe of liver, caudate with a C. Okay, it is made up of caudate lobe of liver. The inferior aspect, it is made up of first part of duodenum rather than first half of first part of the duodenum. This is the first part of the duodenum, so it is made up of first half of first part of duodenum. First part of duodenum, and in posterior aspect, it is not very clearly shown. Actually, here behind this, it runs the inferior vena cava. So here just behind it, there is inferior vena cava. So these are the four boundaries of the epiploic foramen, and it is also known as foramen of Winslow. This is also known as foramen of Winslow. So we did with the lesser sac. Here is the lesser sac shown in the blue. Then what about the greater sac? All the rest of the peritoneal cavity, excluding the lesser sac, is considered to be greater sac. So here the part of the peritoneal cavity shown in the green, the part of the peritoneal cavity shown in the pink, all of it considers to be a part of greater sac. Greater sac is further divided into two parts based on its attachment of transverse mesocolon. Here is the attachment of transverse mesocolon. Here is the transverse mesocolon itself. Here is its visceral peritoneum, and then the mesentery that goes all the way to the back. So everything that is, and add to it the fused greater omentum. Now you just remember that greater omentum was fused to it. So everything that is above this drawn line is considered to be a part of supracholic compartment. Here you can see that above this line, it is labeled in green. It is considered to be a part of supracholic compartment. Everything below and behind it is considered to be a part of infracholic compartment. Remember, I am only talking about greater sac. Lesser sac remains in its place, just like we discussed before. So here you can see that when you have removed the anterior abdominal wall, you can see the stomach, this greater omentum. Here is the transverse colon, here is the transverse colon, this one, and the superior mesentery. So anything that is anterior to it and above it, all of it is the supracholic compartment. If you pull up this greater omentum and transverse colon like an apron, behind it, all of this cavity you see, it is the infracholic compartment. Infracholic compartment can further be subdivided depending upon the attachment of the mesentery of small intestine. So this is the attachment line of the mesentery of small intestine. The small intestine has been reflected towards the right. So anything that is towards the left side of it, that will be the left infracholic compartment. If you move the intestine to this side, everything on that side of it will be known as right infracholic compartment. Now talking about the anterior abdominal wall that we removed previously. If we see the inner aspect of the interior abdominal wall, so if you see the inner aspect of the anterior abdominal wall, it is lined by peritoneum, just like the rest of the peritoneal cavity. Here you can divide it into two parts at the level of umbilicus, the part that is above the umbilicus and the part that is below the umbilicus. The part that is above the umbilicus, here there is a single fold of peritoneum in the midline, this one. This single fold of peritoneum that is in the midline, that is known as falciform ligament. It joins the anterior surface of the liver to the inner aspect of anterior abdominal wall. This layer has a thickening at the lower free margin. This is known as round ligament of liver or ligamentum teres. It's an embryological remnant of left umbilical vein, and here you can see it trace it back all the way into the umbilicus at the lower margin of the falciform ligament. Then in the infraumbilical part, you can see 3 folds in each half. Better yet, 2 folds in each half and 1 fold in midline. The fold in the midline, this one, it seems to rise from the apex of the bladder all the way into the apex. This one. This is known as median umbilical fold with N, and this median umbilical fold contains the remnant of urachus that was a remnant of allantois. Just to the side of it, just lateral to it, there are paired folds on each side. This fold is known as medial with an L, medial umbilical fold. Medial umbilical fold is a fold of peritoneum that is raised due to the underlying umbilical artery. Now, in umbilical artery, it is very important in fetal circulation, but in adults, there is no circulation through the umbilicus, through the placenta. So, this artery has served its purpose, it obliterates, and in adult, it remains as median umbilical ligament. So, it remains as right umbilical ligament, left umbilical ligament. The third fold is this one. Third fold is this one that contains the inferior epigastric vessels on the way to the rectus sheath. So, this is the lateral fold. So, this is the lateral fold. So, now you know the 5 folds in the anterior abdominal wall in the inner aspect. Falciform ligament, 1 median umbilical ligament, 2 medial umbilical ligaments, 3 lateral umbilical folds. And all of these folds, you should know that what are the structures that are giving rise to these folds, what are the structures embryological remnant of, and a very interesting question, a common sense question is asked, which one of the following folds when cut will lead to bleeding in an adult person? Think about it. It will be this fold because it contains actual live vessels. So, we have talked about anterior wall. Now, some definitions. What is ligament? Ligament is a double layered fold of peritoneum that connects a viscera to the abdominal wall. I'll just give you an example of the ligaments of liver. Like here, this is the falciform ligament, double layered of peritoneum that connects the anterior surface of liver to the anterior abdominal wall, just like falciform ligament we saw in the previous slide. Here there is left triangular ligament, here is the right triangular ligament, here are the coronary ligament that join the liver to the undersurface of diaphragm. They give support to the liver. Then here is the lesser omentum that connects to the stomach. Here is the porta hepatis that is contained by this. So, I am just talking about the different ligaments, falciform, triangular, coronary ligaments. They are just nothing more than the folds of the peritoneum that are connecting this organ to the walls and supporting it in process. Omenta, 2 layers fold of peritoneum that connects the stomach to the any other viscus. I think we have discussed it in detail by now. So, we talked about greater omentum. Greater omentum that was covering the greater curvature of the stomach. It extended like a apron-like pattern in front of the small intestine. This greater omentum can be divided into different parts depending upon its attachments. So, greater omentum extends all the way from here to here. This all is greater omentum. So, generally the word greater omentum is reserved for this part that hangs like apron-like portion. The part that is extended from the greater curvature of the stomach to the diaphragm directly. So, this part is now known as gastrophrenic ligament. This gastrophrenic ligament was originally this peritoneum. Now we call it gastrophrenic ligament. Then the part of the peritoneum that is between the stomach and the spleen, that is now known as gastrosplenic ligament. that is known as gastrosplenic ligament. Now the part that is between the and the transverse colon, especially the posterior layer, that is now known as uh, gastrocolic ligament. In gastrocolic ligament, the name can be expanded to all of the apron-like extension that goes all the way down. Now this was the lesser omentum. This lesser omentum, we saw that it can be further named depending upon its attachment. The part that is between the liver and the stomach only, the part that is here, that part is known as hepatogastric ligament. The part that is between the liver and the duodenum only, that part may be known as hepatoduodenal ligament. Hepatoduodenal ligament contains, here you can see hepatoduodenal ligament, it contains hepatic artery, portal vein and biliary duct. So these are the ligaments we just discussed. We just discussed hepatogastric, hepatoduodenal, gastrocophrenic, gastrocosplenic, and here gastrocolic. And splenorenal ligament we discussed in the embryological portion when we were discussing the formation of lesser sac. Epiploic foramen, we discussed the boundaries, and it has very important clinical importance that all of the blood going to the liver, it is going through this, it is going to the portal vein and the hepatic artery, it is going through this. So this point, anterior margin of the epiploic foramen, can be used to stop the bleeding of the liver. When there is a lacerated liver, immediately there is bleeding, you just pinch this point and all of the blood that is going into the liver, it stops. Then you can do the surgical repair and then you can release it on your convenience. So these are the epiploic foramen, we have already discussed it. Mesenteries, these are the double-edged fold of the peritoneum that connects the part of the intestine to the posterior abdominal wall. There are three basic mesenteries. Major mesenteries, the mesentery of the small intestine that connects the jejunum and ileum to the posterior wall. So it starts as the starting point of jejunum and it ends at the terminal point of the ileum. So it starts as DJ junction, duodenojejunal junction, ends at ileocecal junction. This is the line of attachment that joins the two. So it's an apron-like attachment. The attachment to the body wall is very low, narrow, and attachment to the intestine is very large, like it's about 20 feet. So it has a frock-like appearance. It's about 10 to 15 centimeters on this end where it is attached to the body wall, and here it is almost 20 feet that give attachment to the whole of the line of jejunum and ileum. So this is the mesentery proper or mesentery of small intestine. Mesentery of small intestine is also known as mesentery proper, and it's the major mesentery that you see when you open the abdomen. Then there is mesentery of transverse colon. Here you can see the attachments. Here you can roughly make it out, and from it, here this mesentery, it is known as mesentery of the transverse colon. It gives the attachment of the transverse colon and it makes the transverse colon intraperitoneal. The third important mesentery is this one. This mesentery attachment is mesentery of sigmoid colon. This red line roughly demarcates the line of its attachment, and from this line of attachment, this mesentery, it goes and it attaches to the sigmoid colon. All of the three structures mentioned, small intestine, jejunum, ileum, transverse colon and sigmoid colon, are thus intraperitoneal organs. And interesting thing about it is the cecum. Here the cecum is intraperitoneal, but cecum does not have a mesentery. Cecum is intraperitoneal, but it does not have a mesentery. There is appendix here. Appendix is intraperitoneal and it has a very small mesentery. You can see like here. This connects it with to the mesentery proper of the small intestine or the ileum itself. So if you cut the mesentery from the roots, you can see the point of reflection. So here is the mesentery of the small transverse colon, mesentery of the transverse mesocolon attachment. You can see that it starts from the one kidney, ends at the other kidney. Meanwhile, it passes through the second part of duodenum. It passes from the anterior aspect of the pancreas. Then there is mesentery of small intestine, mesentery proper. It started from the duodenojejunal junction. It ends at the ileocecal junction and it goes in a straight line between them. While passing, it crosses the third part of the duodenum, aorta, vena cava, and ureter also. And this mesentery, it contains within itself these vessels. These are known as superior mesenteric artery and superior mesenteric vein. The third mesentery we saw that was this one, sigmoid mesocolon. It was inverted V shape. This point is at the bifurcation of common iliac vessel. This limb, it follows the pelvic brim. This limb, it goes towards the midline, towards the start of the rectum, almost as the level of S3. See, it goes to the S3. Recesses. These are the potential spaces that are created between the folds of the peritoneum. So the duodenum, behind the duodenum there are 4 recesses. One is behind the duodenum itself, that is known as retroduodenal. Then there are 2 folds that are between the duodenum and the inferior mesenteric vein, this one and this one. So they give rise to 3 recesses. The one that is behind this fold is known as superior duodenal recess. The one that is beneath this fold is known as inferior duodenal recess. The one that is behind the inferior mesenteric vein itself, that is known as paraduodenal recess. So these are the 3 recesses here, and this was the mesenteroperitoneal recess, also known as this was we discussed the retroduodenal recess. Then there was cecal recess. One, the part that is behind the cecum, this one is known as retrocecal. There are 2 folds of the cecum peritoneum that are going to the cecum. We will go to in detail when we discuss the intestine itself. There is this one vascular fold contain the blood vessel, this one avascular fold, and beneath the folds, that are spaces that are going beneath the folds, that is superior ileocecal recess, that is inferior ileocecal recess. So this is superior ileocecal recess, that is inferior ileocecal recess. We discuss 3: retrocecal, superior and inferior ileocecal recess. Sigmoid colon attachment was V shape, inverted V shape. So if we pick up the sigmoid mesentery and the space that is beneath this V, that is known as intersigmoidal recess. If we pick up the sigmoid colon, you can see that intersigmoidal recess right here. Spaces, just revision of the names: lesser sac, greater sac. Greater sac has supracolic compartment shown in green, infracolic compartment shown in pink. This was supracolic compartment anteriorly, infracolic compartment behind. Infracolic compartment could further be divided depending upon the attachment of the mesentery of the small intestine on the left side, on the right side. So this was there will be the left infracolic compartment, right infracolic compartment, and this will be the left infracolic compartment. So what are the here in front of the liver there are spaces between the liver and the diaphragm. The space that is anterior to the liver and behind the diaphragm, we have removed the diaphragm in this particular picture. Let me move on to this particular slide. Here the space that is anterior to the liver and behind the diaphragm, these are known as subphrenic spaces or known as subphrenic spaces, because in a person that is lying, it is beneath the diaphragm or phrenic, subdiaphragmatic space. And the space that is behind the liver, this one, that is known as subhepatic space. Let me show you here. So here that anterior wall and the diaphragm has been removed, so you are looking at the subphrenic space, anterior subphrenic space. It is further divided by falciform ligament into the right, left and right anterior subphrenic space. If we pull the liver up anteriorly, behind the liver you can see the posterior subphrenic spaces. So here is the left and here is the right posterior subphrenic space. The right subphrenic space, posterior subphrenic space, it is between the liver anteriorly, and here you can see the kidney. Here you can see the kidney posteriorly. So it is also known as hepatorenal pouch. So it has a very important clinical significance that right posterior subphrenic space, also known as posterior subphrenic space, also known as subhepatic space, also known as hepatorenal space. So these space, when a person is lying down on its back, then this space is the most dependent, the most lowest part of the body, of the peritoneal cavity. This part is very important because in any pathology, if there is a bleed, there is a gut leakage, there is a peritoneal fluid effusion, any type of fluid in the peritoneal cavity, when a person lies down within the abdominal cavity, it will ultimately trickle down to this right posterior subphrenic space because it's the inferior most part. And in the pelvis, the lowermost part is pelvic cavity, and in the pelvic, between the when the highest point will be pelvic rib, and I am talking all of them when a person is lying down on its back in spine position. When a person sit ups, stands up, all of the fluid that is here in the subphrenic space, it trickles down into the peritoneal cavity, and that's why we prefer to prop up the persons. I'll discuss shortly the peritoneal circulation. Here the transverse colon, ascending and descending colon, they are raised. If we cut them like here, we see that when this is the posterior wall, like this will be the ascending colon, this will be the descending colon. So they are comparatively raised up from the. So here on either side there is a depression for a person who is lying down. So these are known as paracolic gutter. This is known as right paracolic gutter, these are known as left paracolic gutter. And just we talked about when the person had a fluid here, when he sits up, the fluid goes through the right paracolic gutter all the way into the pelvis. So the paracolic gutter will be here. We discussed the parts of the infracolic compartment, the right and left compartments. This will be considered as right, and this will be considered as left. Nerve supplying the peritoneum. A golden rule to remember the nerve supply of the peritoneum or any other serous membrane is the nerve supply of the structure, the nerve supply of the layer it is covering. The nerve supply of the layer, the nerve supply of the structure it is covering. So the parietal peritoneum, it covers the wall, it covers the cavity wall. So when it covers the anterior abdominal wall, it has the same nerve supply, lower 6th thoracic nerve, L1, lower lumbar 1. When it covering the undersurface of diaphragm, it has the same nerve supply. In the middle, phrenic nerve, and in the middle there is phrenic nerve, and in the periphery there is lower 6th thoracic nerve. When we go into the peritoneum, when we go into the pelvic part of peritoneum, the same rule applies. The pelvic part is majorly being supplied by obturator nerve, and the nature of the pain, the nature of the sensation carries will be similar to that of the structures that is carrying. That is the wall here, that is the abdominal wall. The pain or any sensation that will be sharp, localized, and it is sensitive to a wide variety of sensation, that is pain, temperature, touch, pressure, stretch, irritation. All of these are visible or sensed on the parietal peritoneum. Visceral peritoneum is covering the viscera. It will have the same nerve supply of viscera, and that is the autonomic afferents. Autonomic afferents you study with each viscera individually. These are from the multiple plexuses that are covering the vessels and all that. So whichever the viscera nerve supply is, that is the nerve supply of the visceral layer of peritoneum. And these are sensible to a less number of modalities, that are stretch, ischemia, and maybe tearing. And they generate a very dull, aching, vague pain that is usually in the midline. And that is very much frequently understood in the case of appendicitis. When there is an inflamed appendix, the pain is through the visceral peritoneum, the visceral in nature, it is felt in the midline at the level of umbilicus. But when appendix become inflamed, it lengthens, it touches the parietal layer of peritoneum, then the parietal features kick in. The pain migrates to this point, McBurney's point, and you feel sharp pain with rebound tenderness. So I am not going into detail of this, but I am just going to show you to whatever the dermatomes of the viscera is, the same will be the dermatomes of the peritoneum, visceral peritoneum that is covering them. The functions of the peritoneum, it ensures that viscera glide easily. There is a lot of movement going on through the peristalsis. In the abdominal wall, with each breath there is diaphragm, you are moving about. All of these movements, the organs, they do not go into the friction with one another, they slide easily with the help of the slippery peritoneum that are covering them. It protects the viscera in a number of ways. The peritoneum fluid and the peritoneum itself is filled up of all the way with phagocytic cells. So any pathology, any cell that gains access, any germ that gains access is picked up by them and removed. There is a regular flow of the peritoneal fluid. The peritoneal fluid is regularly being secreted and absorbed. That leads to the completely changing of fluid and removal of all the pathogens that have been killed, and the turnover of the cells. And it has a very interesting thing that whenever the peritoneum is inflamed, whenever there is a peritonitis or any inflammatory or any infectious disease, the peritoneum becomes sticky. The peritoneum becomes sticky. When the peritoneum becomes sticky, it helps seal off various areas. Very good example is greater omentum. Greater omentum, you saw that it was an apron like and it was free to move about. So when it was free to move about and there is an infection, for example, here is acute appendicitis, this peritoneum, it usually tries to get stuck. So when it gets stuck, it seals off the infection, it seals off the spread of infection, it prevents from a bigger harm. So this is the peritoneum in sticking. Then it has helped in absorption and dialysis. I'll go into them one by one. Absorption and dialysis, healing and adhesion, and storage of fat. Between the layers of peritoneum, the fat may be stored. Let's go into them one by one. This is the circulation of peritoneal fluid. Mostly it is being produced in the lower part on the surface of the GIT. It is being produced, and with the help of peristaltic movement, it is gradually moved upwards, and it usually goes all the way to the subphrenic spaces, and the subphrenic spaces it get absorbed into the blood vessels. Now this point of information, it becomes important because any person that has peritonitis and have bacteria and anything living in it, if a person fluid goes all the way into the phrenic space, it may get absorbed and get entry into the blood, and it may even cross the diaphragm and it goes into the thorax. So that is why whenever we have a person with peritonitis, you try to make that person in upright position so that fluid may not get accumulated in the subphrenic space. The fluid may go into the pelvic cavity, and here you put on the drain that helps to drain the fluid into the any container that you have put down. Also the fluid that is infected fluid, when it goes into the subhepatic space, it irritates the diaphragm and it gives rise to uncomfortable situation and pain. So we'll discuss about the movement of peritoneal fluid. Just discuss that with function of greater momentum, ascites, pain, and peritoneal dialysis. So this is the movement of peritoneal fluid. Just I discussed about it. It is from below upwards, and due to that, to prevent the absorption and the irritation of diaphragm, the person with infective peritonitis, it is usually made to sit upright. Then the importance of greater momentum. One of the clinical features was that we discussed that infection. Whenever there is a function, the peritoneum becomes sticky, it gets stuck to the infection part, and it may help in sealing of the issues. It may help as a hernia plug. For example, a person has an inguinal hernia, has a propensity to get inguinal hernia. He has a very wide deep ring. This apron, it is in front of all intestine. It goes in first and gets stuck itself. When it goes in self and gets stuck itself, it seals the opening. It prevents the inguinal hernia from being developed. Same goes for femoral hernia. Another thing is, it is used frequently in surgery. Very good example is, for example, a person had this perforation. Here this particular picture is actually being drawn for the limitation of the infection, but I am giving another example. If a person has a very good big one gastric perforation, you cannot just seal the opening, it is too big. You can just not seal the opening without wasting some of the stomach. So what we do is, to strengthen it, you put the greater momentum on it like a patch and then stitch around it, and then this patch helps, it gives time, it helps sealing, and it gives time for the healing. Then there is internal abdominal hernias. External abdominal hernias, you have seen that femoral hernia, inguinal hernia, epigastric hernia, umbilical hernias. The external hernia, they move through the abdominal wall into the external. So whenever through the recesses and through the peritoneal folds, whenever the intestine gets stuck, these are known as internal abdominal hernia. A very good example is this one, a very common one, that is known as paraduodenal hernia. This paraduodenal hernia, we just saw that paraduodenal recess behind the inferior mesenteric vessels. The intestine goes behind this recess into this fold. Here it can get stuck, it can cause gastric obstruction, it can cause strangulation and ischemia also. There are a number of ways, and there are a number of recesses in which it can get stuck and cause issues. For example, it can get stuck in the paraduodenal recess, it can get stuck into the lesser sac itself, foramen of Winslow. It can go into the intersigmoidal recess, it can go into the pericecal recess, towards recesses. it can goes through a defect in the transverse mesentery, transverse mesocolon, transverse mesenteric recess. So these are a lot of possibilities that are there. Ascites, accumulation of extra fluid that is in the peritoneal cavity is known as ascites. In clinical and pathological subjects, we will discuss its pathology and its causes. It can be due to a simple infection, peritonitis, biliary leakage. It can be due to some disease that causes the low protein levels, like in liver, kidney disease, and in burn. And there are a lot of causes. It's a whole subject. But here in anatomy, you should know that ascites is the accumulation of fluid between the parietal and the visceral layer of peritoneum, and it has a it is so big, peritoneal cavity is so big that it takes about 1 to 1.5 liter accumulation of fluid before it becomes apparent. Peritoneal dialysis. Within the peritoneum, we saw that there was a large viscera. There were 20 feet of small intestine, there was large intestine, there was number of foldings. So the peritoneal cavity itself, even not so big, the peritoneal membrane had a large surface area due to a large number of foldings. So the large number of surface area and the nature of the serous membrane, that is single layered, it gives an ideal situation for dialysis. So what we do is we put the dialysing fluid into the peritoneal cavity, leave it there. Due to the large surface area, the exchange of material occurs. The fluid, the waste that has to go into the peritoneal space, it comes out, and then we put another bag and we drain it into the exchange. Then we put on the new dialysing, and this process can be continued till it's needed. So that's it. That's about the peritoneum. Thank you so much. If you have any question, put it down in the comments. We will discuss it further in the Google Classroom. I made this video because we could not have a good interaction on online classroom. So I hope this helps. Thank you so much. Allah Hafiz.